International Federation of Kidney Foundations World Kidney Alliance Conference and webinar. We want to do a series of this. IFKF-WKA is an organization with groups from all over the world, and we want to promote knowledge of kidney disease, awareness of kidney disease in patient care. I also welcome Dr. Georgie Abraham, our panelists, Dr. Mumtaz Patel from UK, Dr. Muruganathan, who has very kindly accepted and helped us in this and is hosting this whole webinar for us. Of course, I need to say thank you to Kausi, who's been, doing some selfless service in organizing this along with Dr. Muruganathan. And so before we get into this webinar on hypertension, the silent killer, first of all, I want to say thank you to everyone for joining us. We're very grateful that you're here today. And I want to introduce you to our president, Dr. SF from Hong Kong. He is a nephrologist first, but he also runs the Hong Kong Kidney Foundation. He's our president, and he's done a great job for IFKF-WKA in relaunching us, in taking us forward. And thanks to him, we're all moving forward and getting world visibility and recognition. So SF, over to you. Just a few words about IFKF-WKA before we start.
Yeah, just very quickly. Good evening, good afternoon. This is the new live now, is it? Good evening, good afternoon, and everyone around the world on different time zones. This is the second webinar I have today. Nice to see all of you, not in person, but one day, hopefully, I can visit your country as well. Thank you, Arthur, for organizing this and Kausi. It is good that we can meet under difficult time. As you know, IFKF have been relaunched to include World Kidney Alliance. We're going to involve more patients because they are the most important persons. So our wish is to have better kidney health for everyone. And to do that, hypertension is a major problem. And also better care of patients with kidney disease. Those are the aim, the vision of Kidney Foundation. So I'm very pleased that Arthur and Kausi has actually chosen the title hypertension. Around the world, I understood 1 in 4 in men and 1 in 5 in women have hypertension. I just heard that in India, you may be looking at 1 in 3, okay? So it's a quite a major problem. And we were just chatting beforehand. Same in Hong Kong, half of those who got hypertension do not know they have hypertension. And half of those who have hypertension are not managed well. And the consequence is bad because it damages your kidneys, it damages your heart, it damages everything else. So it's good that you're choosing the title. And I think we will have a regional favor. We'll be very interested to hear how you're doing, what's your issues in India and what you are doing for your patients. So thank you very much for joining us.
Thank you, SF, for introducing IFKF-WKA. You have done a great job as president, and we look forward to all the activities that you've planned, which I think all our members will know gradually. We invite everybody else also to join the IFKF-WKA. So without any delay, let me introduce Dr. Georgie Abraham. He is a consultant, nephrologist from MGM Healthcare, Chennai. He is the person who introduced CAPD to India after learning from Dr. Dimitrios Oriopoulos, and which has become, more used now, continuous ambulatory peritoneal dialysis. He's the founder of a kidney foundation called Tamil Nadu Kidney Research Foundation, Tanker Foundation, which helps 670 patients by giving free and subsidized dialysis. Dr. Georgie Abraham is a person who is always ready to help and wants to do more and more, study more and more research, and wants to include everybody possible in everything. So Dr. Georgie, I would now ask you to introduce our panelists, our wonderful Dr. Mumtaz and Dr. Muruganathan today. Thank you.
Lata, good evening, good morning, and good afternoon. And distinguished colleagues from India and abroad, Dr. Louis, Alan Haynes, Dr. Mumtaz Patel, and distinguished colleague from India, Dr. Muruganathan. First, we will have 2 talks. First is Mumtaz Patel, followed by Dr. Muruganathan. First, I will introduce Dr. Mumtaz Patel. Dr. Patel is a consultant nephrologist based at the Manchester University Hospital NHS Foundation Trust, and she is an international advisor as well as the international vice president of the Global RCP London since July 2020. She graduated from the University of Manchester, United Kingdom, with the MB-CHP honors degree in 1996, followed by MRCP UK in 2000 and FRCP London in 2011. She is a specialist in nephrology and undertook Wellcome Trust-funded PhD research project exploring the genetics of lupus nephritis. And she is an expert on lupus nephritis and vasculitis. And she has specialist training undertaken at Yorkshire Deanery and obtained specialist registration in nephrology in 2007, appointed as a consultant nephrologist at Manchester University Hospital Foundation Trust in 2007. She's the regional lead for vasculitis. And one moment, please. She developed an increasing interest in medical education during consultant post and appointed as Renal Training Program Director for Northwest Deanery in 2012, appointed RCP Tutor, Divisional Education Lead at MFT 2013, appointed and Regional RCP Advisor in 2015, and Postgraduate Associate Dean for Health Education, England Northwest in 2016. She also holds an MSc in Medical Education and awarded distinction for work looking at the value of workplace-based assessments in predicting doctors in difficulty, presented many papers at the national and international meetings and published in medical education. And she is also appointed as clinical lead for quality management for the Joint Royal Colleges of Physicians Training Board in 2016. And she published reports on the state of physician lead training in UK in 2017 and 2019. Currently, she is leading on national work on different attainment and assessment. On top of that, she has endless humility and simplicity and is always willing to support developing countries in education and clinical work. So Mumtaz, it is up to you to start your talk on hypertension.
Thank you so much, Georgie. It's very kind, very humbling. And welcome to everyone. And thank you so much for inviting me to this webinar today. A huge thank you to all the organizers and presenters. I'm just going to share my screen with a few slides, if I may. Can you see that okay, Georgie and everyone? I will just make it a little bit bigger. Is that all right? Okay. So I've just prepared a very short talk, hopefully just to introduce the issue around hypertension, the silent killer. I don't need to introduce myself as you've done it so nicely, Georgie. So the outline of my short presentation is around, so I have different roles. So for the Royal College of Physicians, as Georgie mentioned, I'm the Global Vice President, and as a clinician, I'm a kidney physician, renal consultant, like Georgie as well. So what I wanted to go through was just maybe, kind of an overview of our global strategy, vision and mission, in which we are, one of our strategic objectives is around prevention. And a lot of what we're talking around today is around prevention and improving healthcare for all. And hypertension, the silent killer, I guess what I wanted to do is just give a little bit of a background, just go through some key facts, present more the scale of the issue, but look at it both from a UK perspective, but from a wider global perspective, given the nature of the discussion today. And I guess my background as a nephrologist, but also as a general physician, just to share some thoughts and views, and hopefully that will lead us nicely to our panel discussion. So our Royal College of Physicians strategy, which was approved earlier this year. So our vision is to provide best health and healthcare for everyone. That includes our international community. And our strategic objectives within the mission statements is around educating physicians to their potential, influencing the way health and healthcare is designed and delivered, and improving health and care, and leading on prevention of ill health across communities. And the recent WHO reports talk about a focus on non-communicable diseases, of which hypertension is a major issue, which we'll go through. And of course, that fits in widely with our broad strategic aims and principles as well. So the silent killer, hypertension, sadly, we see it all the time here, also in the UK. And what I guess the term means, as I'm sure some of the audience are already aware, is that despite hypertension being ever so severe at times, it may not give rise to any symptoms whatsoever. One of the first patients I saw as a junior doctor with a massive, kind of bleed, which led to, kind of undiagnosed hypertension for a long time, coming from an underprivileged background. And then even when diagnosed, it was very difficult to manage and control. So it is very much a silent killer, and the long-term problems, both risks of getting it, but also the implications and complications of chronic disease is huge. And I guess from a renal perspective, we see a lot of patients with progressive renal disease, kidney failure, but given that cardiovascular problems is a big part of what I do as a renal and general physician, we see lots of cardiac complications as well, stroke, unfortunately, both mini strokes, TIAs, as well as kind of major strokes and bleeds, and visual loss. Only last week, I saw a patient with really terrible a sort of visual loss from previously undiagnosed hypertension as well. So just going through some key facts. So what we know, hypertension, as in high blood pressure, is a serious medical condition which significantly has risks on heart, brain, kidney, as well as other diseases. Globally, it's a huge problem. 1.28 billion, they say, sort of young adults globally have hypertension. And most, 2/3 of these are within low and middle income countries, sadly. And up to half of the adults with hypertension are unaware that they have it. And less than a half, 42% or so, are diagnosed but poorly treated. 1 in 5 of patients with hypertension, sort of control could be a problem, and compliance issues as well. And it's a major cause of premature death worldwide. And one of the global targets for non-communicable disease is to reduce the prevalence of hypertension by 1/3, if possible. And you'll see 1/3 mentioned a lot in my presentation. So if you take anything away, take away some of the figures, because they are quite astounding. So the scale of the challenge globally. So 1 in 3 suffer from hypertension. 1 in 3 adults of hypertension may have this, but it goes undiagnosed. And then 1 in 3, again, even if they are diagnosed, they are not treated optimally as well, both for compliance issues, but also with difficulty in managing hypertension as well. And when you look at the prevalence of hypertension globally, what are the issues? So when you look at, I guess, Africa, South Asia come highest as far as prevalence is concerned, 27, 25%. Europe and Eastern Mediterranean countries are not far off, around 1/4. And the Americas, I guess, are sort of, as far as percentages are concerned, are slightly lower. But globally, 22%, 1 in 5. This is not good. And this is the people who are diagnosed, the ones who pass away with the silent killer aspect of. So probably this is an underestimate of the true prevalence of hypertension. And in the UK, what's the scale of the issue here? So again, here, up to 1/3 of adults have high blood pressure, and around 1/2 of those don't know they have it. So if you go away with anything, it's 1/3 and 1/2 who don't know in most sort of areas as well. And about 1/4, when diagnosed, sadly either don't take medications for it or are on medications but are poorly controlled as well. And then that undiagnosed hypertension, as the title suggests, in England, more than 5.5 million people sadly have undiagnosed high blood pressure. So for every 10 that you diagnose, there are probably a further 7 who are not diagnosed and not treated. So such a huge scale. And why is it important? So it's important because of the damage it can cause to the individual patient, but also, widely speaking, from healthcare system perspective, it's a huge cost, so prevention is always better than cure. So patients having horrible, very damaging strokes, coronary heart disease, eye problems, kidney problems, huge burden, kind of to both the individual getting it, but also broadly speaking to the healthcare systems as well. And we know that, kind of it's the biggest risk factor for premature death and disability after smoking and poor diet. And the thing at the bottom, around a third, 30%, sadly, even in England, a lot of patients that we have with high blood pressure or are not diagnosed live in the most deprived areas. So it seems, health inequalities is exacerbated in these conditions, sadly, as well. So people who have less, who are more socially deprived, sadly get this more so and have more complications associated with it. At least half of our heart attacks, strokes, etc., and chronic kidney disease, as far as risk factors are concerned, hypertension, diabetes, etc., are highest as far as prevalence things are concerned. So as I've mentioned, prevention we know is better than cure, and education is the key. And I hope we discuss this when it comes to our discussion points as well. So how to prevent hypertension around healthier eating, more exercise, avoiding, sort of some of the other risk factors, and just generally being active. Numbers, monitoring, regular sort of monitoring is something which would be really important. But again, access is an issue as well. So if you have no symptoms, it doesn't mean you don't have, or you have normal blood pressure. So even health workers should regularly check both your own blood pressure, but others as well. And people may have blood pressure problems without any symptoms or signs. So it's so important for regular monitoring to be there as well. And global initiatives wise, so there's lots of things that are out there, but I guess access is an issue as well. So the World Hypertension Day earlier this year was observed back in May. And we know that it's such a huge risk factor, more than 10 million people suffering worldwide. And again, raising awareness is so very important around prevention, treatment, and control. And the WHO have done a lot of work around it. And just in September, there was a response more formally around supporting countries to reduce hypertension as a public health issue, raising awareness. New treatment guidelines have been published just recently through the WHO, which outlines evidence-based recommendations, both for initiation, control, and management and longer-term care. And it outlines more of a healthcare system responsibility. So everybody a shared responsibility for all to take ownership of this as well. And around a program of partnership working and a much more strategic approach around healthier lifestyle counseling, evidence-based treatment, access to essential medicine, more risk-based management as well, and team-based care, and having systems for monitoring as well. In the UK, as well as in other places, there's a lot of guidance. So the NICE guidance is our National Institute of Clinical Excellence, but we have the British Hypertension Society, we have the Cardiology Society, lots of evidence out there, lots of guidelines and recommendations. So I'm not going to go through all of that, but there are a lot of measures around recommendations, but it's how we practice those things and systemize it as well. So from my own personal experience, the last couple of slides is to say, sadly, I've seen many patients over the years with undiagnosed hypertension with organ damage, whether it's renal, cardiac, strokes, visual, lots of problems. Many patients who are diagnosed with hypertension still have lots of difficulty managing their blood pressure. Polypharmacy is a huge issue, drug side effects, interactions, particularly in our renal patients, and compliance remains a significant issue, both in our renal as well as our general patients. And that importance of equity of access and care is striking with patients from socially deprived backgrounds as well. And sadly, they're more likely to get both hypertension, diabetes, and other problems, and greater risk of complications. So there's a real need to try and help and support these underprivileged communities as well. So the key points I feel need to be considered and may be helpful for our discussion today is how can we work more effectively to address these issues, improve access, point of care for patients in low middle income countries, but also in more socially deprived areas as well and underprivileged areas. We know education is a key, but how do we improve the coverage of that? How do government and organizations work better to address these issues and more in a stepwise way? And there is a need for a much more strategic approach to both raise awareness, but also improve education around prevention and access, and have a much more targeted approach for management. So thank you so much for listening. Sorry, a whistle-top tour, and I didn't want to dominate the whole session. So I hope that's been helpful and hopefully helps us with our discussion shortly as well.
Thank you, Mumtaz. Let's go to the next speaker, Professor A. Muruganathan, who is the chairman of AG Hospital in Tirupur, Tamil Nadu. He is a visionary with a lot of enormous efforts put in for hypertension diagnosis and control in this country. And he is the ex-emeritus professor, the Tamil Nadu Dr. MGR Medical University, immediate past governor, American College of Physicians, India chapter, Dean, Indian College of Physicians, past Dean, and President, Hypertension Society of India, past President, Association of Physicians of India from 213 to 214, past President, Tamil Nadu, Dr. MGR, Tamil Nadu IMA, and past Dean of IMA CGP, editor of Adult Immunization 2014, Progress in Medicine 2017, and Medicine Update in 2013 and 2017. Yeah, and also Manual of Hypertension in 2015 and 2019. The awards received were B.C. Roy Award from the President of India in 2005, WHL Excellence Award in Population Hypertension Prevention and Control in 2021, Sakura Excellence Award 2021 from ACP Jaipur chapter, received Best Performing Doctor Award from Tamil Nadu government in 2014, received Lifetime Achievement Award from Dr. MGR Medical University, Indian Society of Hypertension, Savitha Medical College, University, KG Foundation, and Dr. Mohan's Diabetic Foundation and Indian Society of Hypertension. Dr. Muruganathan, can you now come to the floor and start your talk?
Yeah, actually, Jaji, what do you want me to do? Now the Professor Mumtaz has clearly given the basic facts about hypertension. Should we go on interaction discussion, or you want me to talk about community options? How do we improve the awareness? And
yes, I think that will be important, because we are in a developing country. We have a huge burden of hypertension, enormous burden. So with your experience on that, and it will enrich others, because we have audience from other parts of the world as well.
Okay, because I got all slides. You know, I got management. I got difficulty in treating hypertension, but I'll prefer this community option.
Sure,
okay.
Dr.
And after my talk, maybe we'll have a discussion.
We'll have question and answer session with both the speakers after your talk.
Yeah, I request our beloved delegates, please put your questions in the chat box. We'll have a lively discussion. The blood pressure measurement in the community setting, options and implications. Actually, why it is important to measure blood pressure, need for BP measurement in the community center, economic burden of hypertension, my experience and success stories, implication, what is the role of physician, future directions and goals. The discovery of the blood pressure was more important than the discovery of the blood itself, says John Muller, a German anatomist. So important is the blood pressure discovery. And again, another interesting thing, I don't know how many of you agree, but Christian Barnard himself said, I have saved the lives of 150 people by heart transplant. If I had focused on the preventive medicine earlier, I would have saved 150 millions. This is very true. So many people in India, physicians are now preventing hypertension, preventing complications. So we are really good, and we are really saving so many lives. Now, the population monitoring and screening of blood pressure is an important part of any population health strategy. Our beloved speaker has mentioned about WHO statistics. What is called WHO protocol, like it's called HEARTS, HEARTS, where he says about health lifestyle, evidence-based treatment protocol, access to the essential medication, risk-based management, team-based management, and systematic strategy. So that is the HEARTS introduced by WHO. So every country has got their own protocol of managing hypertension, creating awareness. The substantial and growing burden of non-communicable disease, many of which are associated with hypertension, has necessitated population-based strategies for monitoring and screening blood pressure. So population-based strategies are very important, especially in developing countries. WHO recently said number of people living with hypertension has doubled from 1.28 billion since 1990. The third most common cause of death and disability, affecting more than 20 crores of people in India. Of course, in every country, less than 30% aware. I think the president of Lee also had said, even in this country, 1/3 aware, 1/3 treatment, 1/3 control. This is the WHL, World Hypertension League, recommendation for public health actions for national hypertension organizations, international organizations. What is that? It says increase awareness that hypertension is largely preventable, but is a constant threat to well-being as the world's leading risk for death and disability. Not corona, not COVID, not the communicable disease. It is hypertension. Again, increase awareness that hypertension is largely caused by unhealthy eating, especially high dietary salt, physicians' inactivity, obesity, and excessive alcohol and smoking. Increase awareness that hypertension can be inexpensively and easily detected and clinically managed. So this is the WHO recommendation for public health actions for all the national hypertension organization. And then hypertension in rural India, the contribution of socioeconomic position. The conclusion was the Pew study, education is widely considered, as the previous speaker very well demonstrated, education is widely considered to ameliorate the risk of hypertension in high income countries. But why this effect is absent in rural India merits investigation. So hypertension, Pew study says the awareness is low, we must have education. All of us, all the associations like IKF, every organization should involve in the education. Again, the hypertension prevalence in India is high, but the proportion of adults with hypertension who are aware of their diagnosis or treated are very low. So again, a nationally representative cross-sectional study says you should create awareness, screening, and treatment control. Okay, I already told you how many people are aware, having hypertension in India. This is I always say hypertension is hemodynamic malignancy. It's a hemodynamic malignancy. If you see all the causes, high blood pressure, more than 9.4 million deaths every year in this country, in the world. So tobacco smoking comes at the second. If you see diabetes comes much later. As I said, it can cause heart failure, infarction, peripheral vascular disease, retinopathy, chronic kidney disease. And the one interesting factor with the kidney disease, because I am with the 3 or 4 internationally renowned nephrologists, Georgie and Mumtaz and Leo. But hypertension is the cause and the effect of kidney disease. Hypertension can be there because of the kidney disease, or kidney disease can come because of the hypertension. That's the relation. Again, in a community center, what all the things we must do? In the developing countries, compared to developing countries, hypertension is not at all, a big problem. They all think it's a silent killer and nobody bothers. That is why we had been, talking in various forums that we must do screening, and create an awareness. Hypertension is silent killer, but we cannot be silent. We must make some noise. In fact, I congratulate the organizers of this program. They're creating international media, international podium to create an awareness about hypertension. Then options, I always say PPP, practitioners, physicians, pediatricians, obstetricians, surgeons. Then people education. You must empower, especially pregnancy patient, pilgrimage people, that they should know how to measure the blood pressure. The other day I was talking to Georgie, he was saying the pregnant women also you must make a mention. Really, if you see, most of the patients in the pregnancy, they developed hypertension, pregnancy-induced hypertension, eclampsia, pre-eclampsia, and then the fetal mortality and the mother mortality so much. So you must empower the patients of pregnancy as well as general patients, especially pilgrimage. When somebody goes for any pilgrimage, they don't care. They don't carry their medicines. So they don't also check the blood pressure. Pupil education institution. I think we must start the education about the awareness. We must start with the school and colleges. The other day I went to a small school. where I talked to them about hypertension measurement. Believe me, in even that school, I had at least 2% people had hypertension. So we must teach the teachers. It's the best way to teach the students is to teach the teacher, and the teacher will teach about hypertension. Private sector, we must involve all the private sector, banks, public sector, government, panchayat, municipality, corporation, public media, all the television. Every time I request, last week I spoke in the national TV, NDTV, about hypertension. So you must also involve the media. Then physicians, patient friendly technology. See, any technology now should be friendly. We have got lots of apps available. And now everybody is using WhatsApp in the mobile phone. They know how to handle mobile phone. So you must have a patient-friendly technology whereby you can create awareness about hypertension. Physicians, hypertension societies. There are so many associations like Hypertension Society of India, Indian Hypertension Society, Nephrology Association. All these associations should have a teaching program for both doctors as well as the public. Okay, then the NRC Campbell said, non-invasive blood measurement devices and blood pressure measurement in the clinical community setting is the need of the hour. The World Hypertension League has made the increase in regular BP assessment and encouragement widespread BP screening programs linked to diagnosis and clinical management of hypertension to be among the highest priorities. And then in the community screening gettings, non-invasive BP assessment is semi-automated or fully automated oscillometry BP device that uses a range of upper arm cuffs. A recently trained observer be used to estimate BP only where automated measures are not feasible. So a lot of gadgets have come. Very good BP monitors. Those are the days when we say the home BP monitor is not good. Nowadays, there are good, validated, internationally approved BP monitors. So my message, one message to all of you, please promote home blood pressure monitoring. Everybody knows home blood sugar monitoring, but not home blood pressure monitoring. So it is very cheap now in India. Everybody can buy. And if you buy one instrument, it is useful for the family. It is useful for the whole society. So the government and non-governmental organization to ensure all communities around the globe have BP screening programs that use semi-automated or fully automated BP machine, and with the hypertension training to all the paramedicals and medicals, we can do mass screening. And then health checkup screening camps. We must organize very many health screening camps with the use of all the organizations like Rotary, Lions, IMA, professional bodies. And then we must also develop hypertension center of excellence. In fact, Georgie, I was talking to Swami Kannu of the MGM Center, MGM Hospital. Why don't you start a hypertension center of excellence? For example, everywhere in this country, we have diabetic center of excellence. We don't have any hypertension center of excellence. Now in MGM, you have the nephrologists, you have neurologists, you have cardiologists, you have ENT people, you have ophthalmologists. You start this hypertension center of excellence. One place, one roof, you treat all the hypertension complication, also diagnose secondary hypertension with the lab which you have. So we must promote hypertension center of excellence and focus on hypertension center of excellence. These centers periodically go to the very many villages, adapt villages, conduct programs, conduct trainings, give training to everyone. So that is the purpose of the hypertension center of excellence. Then what we should achieve by screening, you must identify persons with high normal BP. If the BP is high normal, tell them to undergo lifestyle modification. Pre-hypertension and advise preventive measures like lifestyle modification, early detection of hypertension, and manage to prevent complication. To treat hypertension and target organ damage aggressively, to detect and to treat associated risk factors, proper follow-up and suitable advice with documentation. Because we don't have a documentation, we don't have a hypertension registry. So we must start doing the hypertension registry, preventive care and screening for high blood pressure, follow-up documented national quality strategic domain, community population health. This is the American Medical Association 2014. My experience and success stories. I told you when somebody went for a Hajj, I only taught the person how to check the blood pressure, and his pressure was 154/94. And after that, he started checking the blood pressure for all these Hajj pilgrimage passengers, and they were very happy. Their pressure was controlled and measured. I gave one blood pressure monitor to a vegetable vendor. The vegetable vendor had a blood pressure. I taught her how to take the blood pressure. She started taking the blood pressure and then controlling the medicines and then informing me. Now she's very good. She comes to my clinic every time I teach them and counter check with the pressure machine what she has. Now she's very comfortable. When somebody comes to buy vegetables and fruits, she checks the blood pressure also along with giving the fruits. So her, the vegetable vendor is having a very good business. Recently, I was told somebody gave him extra money for measuring the blood pressure for her also. Anyway, in barber shop, this is one paper I published in the recent international hypertension conference, where the barber shops can be used to monitor. Again, I gave BP monitors to the police station. The commissioner of police is receiving the BP monitor, and everybody in the police station is aware when somebody comes and waits. Then in BP pharmacies we take the blood pressure. Also, this is the paper which I said, sustainability of the blood pressure reductions and interventions led barber shop systematic review and meta-analysis of randomized control trials. This is International Society of Hypertension in 2021 name. Again, I told you PB in public places and COVID and hypertension. I'm very happy. The COVID has taught so many things for us. One of the thing is the hypertension. Many people with hypertension, when they have COVID, they did not buy medicines because of the anxiety. They don't go out. They don't buy medicines because of the anxiety and fear and business loss. They get hypertension. So what is controlled hypertension in COVID time? It becomes uncontrolled. It becomes resistant. And how do we manage? Only with the help of home blood pressure monitoring and thanks to telemedicine and WhatsApp. Again, lockdown hypertension because of the anxiety, fear, loss of income, no exercise because everybody cannot go out, not having enough tablets, very useful for monitoring from home. And this is where I gave the monitors in Gangtok, where the hypertension prevalence is more. And then in library, one of the places, if you teach the librarian, when they come around, say they'll check the blood pressure, will be useful a place for checking the blood pressure. Again, I told you school and school teachers. And then this is what I have given. It's a very interesting article I wrote in the Hindu. I said, whenever you go for any birthday, if anybody is going a 60th birthday or wedding anniversary, don't buy fancy items. You buy only BP monitor, give it to them, give it to the person. Then that will be useful for the whole family. I am very happy because it is not only useful for the patient's mother, mother-in-law, father, father-in-law, and whole family. So early diagnosis, awareness by BP monitor is very good. But unfortunately, blood pressure measurement is very simple, but we don't have a proper method. So spend some time, educate the patient. And this is how you should do. I think the previous speaker has mentioned, it should be quiet room. It should be comfortable. They should have passed urine. They should not talk during the phone. During the measurement, back supported. All those things, you must teach. And every clinic, I request whoever doctor is listening, take a video and play it in your reception hall, so that whenever somebody comes and waits in the room, they know how to check the blood pressure. Again, recently I wrote in the Hindu again about the incidents, why it is important. A person waking up with a stroke or heart attack is a common scenario in today's life. These problems of heart attack and paralysis of one side are mainly due to high blood pressure, which is a silent killer, which I said and the World Stroke Day. Again, hypertension clinic, I've already told you, and then registry I've said, and then this is the one paper which says community-based blood pressure measurement using electronic devices, a validation study in Malaysia. And then I trained about 300 medical representatives about how to check the blood pressure. I used them in a big festival areas, and also home visits. We have a lot of ASHA worker and AYAs. When they go, they not only check the blood pressure, they distribute the medicines. Recently, I am also a senior consultant of vital statistics, resolved to save lives. One of the partners of the WHO and ICMR and state government and central government, we make every ASA workers to go to the place, check the pressure, also give 1 month full of medicines so that we ensure that tablets are given. I told you, you adopt a village and the center of excellence, for example, MGM center can adopt many villages, and then they can do consultation in telemonitoring, and then they can treat. Shopping malls, that is the place, very busy place, happening place. All the poor husbands will be waiting outside at the mall, and when there is somebody there to check the pressure, you can check the pressure there, and you can create an awareness. The flats, if you give the flat secretary or the owner, the BP measurement can be done easily over the flats. And this is the Ganavati festival where there are a lot of people, and I used the 300 medical representatives to check the pressure on the festival day to create an awareness. And again, blood pressure in children and adults is very, very important now. And I have told you, in the railway station, in the airports, in the Indian banks, and then corporate sector, everywhere you can do this. And then I told you the translation of the home readings by the telemonitoring and telemedicine is a very useful instrument. You should have a van, mobile van, where you can go and check the pressure, also distribute medicine, do a ECG in the villages and in the places where you cannot get access. Of course, home BP monitoring should be promoted. I already told you the future aim should be compulsory community screening. Make in India home blood pressure monitoring, affordable cost is available. Telemonitoring in every hospital, collecting Indian data, working with industry, better mobile app, school teachers to be trained, more volunteers, more hypertension clinics, more hypertensionologists. I also request Mumtaz Madam to understand there are diabetologists, there are endocrinologists, but unfortunately, even for COVID, there is COVIDologists, but we don't have any hypertensionologists. So this phrase is not there in the dictionary. So we must introduce this term, and we must make sure a person who's got passion, who's got enough experience to be a hypertensionologist. And this hypertensionologist can be trained by various associations, like Royal College of London can have a one-year course online or offline, and then train more hypertensionologists. So in every house, there is a person who has hypertension. Home BP is very important. Like kindly promote, popularize home BP monitor. So learning is the beginning of health. Learning is beginning of wealth. Learning is beginning of spirituality. I agree with the previous speaker. Education, 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 which can create awareness. Thank you, Georgie. Over to you for further discussions.
Thank you, Professor Muruganathan, for that wonderful, lucid, and inspiring talk. And I'm sure that I have learned quite a bit from your talk. And you were emphasizing on teachers in the school having the blood pressure technique to be taught so that they can check. Because when you ask most of the people, they are unaware of the fact that as per the American Society of Pediatrics, the blood pressure should be checked from the age of 3 in every child, because the incidence of hypertension in children is 0.6 to 2.1%. And majority of it is due to secondary hypertension. So I'm sure that your talk was quite an impressive one, and you have given me a lot of ideas to take it forward through Tanker Foundation. And so thank you so much for that very interesting and inspiring talk. So we can take some questions if we have some questions. Otherwise, I can moderate the session by asking the questions to the speakers.
Dr. Sanjay Kumar Gupta wants to know, how do we manage hypertension and chronic renal failure?
Mumtaz.
Yes, thank you, Georgie. So yes, I guess the risk of hypertension in chronic kidney disease, both as a cause and an effect, is even greater. So earlier management, kind of the usual cardiovascular risk factors, prevention, lifestyle changes, as we've said, but then the medical management would be initiated early. So, the targets that we aim for in our renal patients is lower. So 130/80 would be what we would be aiming for. And then depending on the risk stratification, we would use the medical sort of management for those. So whether it's calcium channel blockers, beta blockers, whatever the medication, but earlier sort of detection and management is key. The lifestyle modification changes and all the prevention stuff that we heard from our previous speaker is all very important as well, in line with the medical management. I hope that helps.
Thank you, Dr. Mumtaz. I just want to ask one question. We have 30 million pregnancies in India every year. This was the statistics given by our Honorable Minister of Health, Ghulam Nabi Azad, some 10 years ago. I'm sure the pregnancy rate would have increased. So 30 million pregnancies, that means, the half of the population of United Kingdom. So pregnancy-related high blood pressure, complications of high blood pressure during pregnancy. So we are like, India is like day and night. In some parts of the country, the infant mortality rate is very low, including Kerala and Tamil Nadu, whereas in other parts of the country, it is as high as nearly 20%. So a lot of this may be related to uncontrolled hypertension. So I want Dr. Mumtaz Patel to comment about the women's health regarding pregnancy and hypertension.
Yes, so that's really, really important, isn't it? And this is the additional risk factors around hypertension. So I think certainly in the UK, the monitoring is much better in antenatal care. So as soon as a positive pregnancy test, the general practitioner, our community physician, would refer the patient for antenatal care. And then that would be regular blood pressure monitoring thereafter in a clinic setting, but also anybody who has mildly elevated hypertension, they would be given a blood pressure monitor or advised to buy one to regularly monitor at home. So very early detection, early intervention is key I think that's the theme of today's webinar anyway. But I loved our previous speaker saying about giving presents to families at weddings of blood pressure monitoring, because in the community, if there's not access to blood pressure monitoring, how do you do it? So in our pregnant ladies in low middle income countries, if they don't have so much structured antenatal care, then it would be a personal responsibility, isn't it? So particularly in the community, in the rural settings, if there is provision of blood pressure monitoring earlier, then that would help. But certainly in our patients that we see, particularly our renal patients, we have a pre-pregnancy counselling service for our renal patients who have complex, renal autoimmune disease. So they have a discussion even before they fall pregnant, so that they could have a risk stratification and then management plan. So those kind of things are important. But if the access isn't there, then I think it's how we can enable and help people to have that access in the community.
So
Jaji,
Doctor,
Jaji,
there are four more questions.
I may add, sorry, Lata, I may add in my Indian perspective, Georgie, about pregnancy hypertension. Georgie told me, because I always, Mumtaz, whenever I speak with a humorous way and send the message. In fact, there is a lot of debate going on whether the pregnancy rate is increased during lockdown or decreased during lockdown. So that was a interesting debate. They were saying, some people say because of the lockdown, people have nothing to do, they are at home, more pregnancy. So again, when the pregnant patients getting hypertension, it is a big problem, especially if somebody has got chronic hypertension, they carry on with the hypertension and they become pregnant. That's one part. The other part, if the pregnancy person gets hypertension after 20 weeks, it is gestational hypertension. And again, if the gestational hypertension has got the proteinuria, it becomes preeclampsia. And if the patient develops fits, it's eclampsia. So if you see preeclampsia, eclampsia, gestational hypertension, chronic hypertension, it's about 10% of the people in India has got that. But unfortunately, if you ask me how many of them are aware in India about pregnancy hypertension, no, not much. That is why I was telling everyone, any pregnant woman, any obstetrician, now the Obstetrician Association of India have come up with some guidelines. Anybody who comes, they should check the blood pressure and they should have the home blood pressure monitoring. One caveat is the BP monitor for the pregnant patient is different, and also the accurate measurement is different. Suppose if you want to check the pressure, you should put them on the lateral decubitus position or sitting, and that's the way you have to do. And another thing which I must say, just like any other edema, you cannot treat with diuretic. I may be wrong, Georgie, correct me. You should not allow diuretics, because this edema is not due to regular cause. It is a vascular permeability and venous constriction. So edema, you should not give diuretics. You should not also do salt restriction in pregnant women. So these are small things we must educate. And after the pregnancy, the delivery problem is so much, premature delivery or any number of days less, then the outcome is bad. If you see 10 years of the prognosis, the people with this premature delivery and all that, they are definitely going to develop cardiovascular problem. So this is very alarming. So I think pregnancy hypertension and pregnancy management is a very, very unique subject. I think obstetrician and physicians should cooperate and do a big program and do it in India. And as you rightly said, awareness, to create an awareness, again, home blood pressure monitoring, and then all the people in the country should know. Whenever they do any pregnancy function, I always tell them, check the pressure for the woman and also for the people who are coming there. Sorry, Georgie, over to you.
Dr. Georgie, there are 5 people who've asked questions. So can I read out the questions to you?
Yes.
Okay. Purnima Kashyap says, how can it be brought to normal? What are the practice of food habits? Dr. Gauri Shankar from Coimbatore asks, do we have to check BP only on suggested sitting position or else is supine position allowed? Then Dr. Sanjay Kumar Gupta has asked, if BP is more than 140, 140/90 after lifestyle modification, then can we start a single drug or 2 drug combination in small dose?
Lata, please. You ask one by one. If you give all 5 questions,
by
you will
one.
not answer.
One
You
by
ask
one
one question, you address to
Yeah.
somebody, and then
Okay,
you will ask. Yeah,
okay.
because
So-
you are answering.
So we want to know whether it can be brought to normal with practice of food habits.
Muruganathan.
Yeah, if somebody has got a blood pressure of more than 140/90, I will request them to check again. See, whenever you, especially in pregnancy hypertension, if somebody has got 140/90, you should check the pressure after 4 hours. If the blood pressure is more than 160/110, you should check the blood pressure in 15 minutes. These are the guidelines. Okay, once you confirm that it is more than 140/90, we normally give, especially in Indian setup, 3 months lifestyle modification. Believe me, no lifestyle modification, in my opinion, it's effective. Though we advise them, definitely they require medicines. And now in the international guidelines says, even if there is 140/90, above 140/90, you start with the combination pill. That'll be better. And if you can reduce the pressure to less than 120, around 130/80, if the patient can tolerate without any problem, that is the best thing. But of course, step by step, we go, advise them about lifestyle modification, give them a blood pressure monitor, ask them to come back with more readings. Then at least 3 months, let us observe the lifestyle modification. Then we can start the treatment. And when you want to start the treatment, the international guideline says, give a combination pill. Even if it is half tablet of amlodipine and telmisartan is good. That is what now the people say, because there's one more concept has come. It's called time in target. The blood pressure should be controlled all the 24 hours, all the 365 days. This is called time in target, which can be achieved only by double drug or combination therapy. Thank you.
So
I just want to add one more comment to that. See, developing countries, especially South Asia and Africa, people take alternative medicine. So whenever you are seeing a patient with high blood pressure, to reduce the complication, we should always have a question asked and confirm whether they are taking any alternative drugs which can lead to high blood pressure. And sometimes people will not come and reveal that they are taking painkillers regularly. These painkillers can also, which are cheaply available over the counter in India and in other South Asian countries, can increase the blood pressure. So please always ask them about alternative medicine when you talk about hypertension control and lifestyle modification.
Okay.
Yeah, I will add with Georgie's point. Not only alternative medicine, even the normal allopathic medicine. Somebody will take. I know one of the English professor. She is very good, very educated person. But she had hypertension. We didn't know what was the problem for controlling. She is a Brahmin lady. She likes curd rice and pickle. So she always take curd rice and pickle. And also she has got a nasal congestion. So she was taking nasal decongestion, taking salt, pickle, and she was taking treatment. So only when you go into the history, you can stop this, as I said, NSAID or ginseng, for example, ginseng, they say vitamins. So all these things, may cause the hypertension. So proper history is very important. I agree with George Abraham. You must spend some time with the patient. What sort of, person, what sort of environment and things like that. Even the pollution, it can cause hypertension.
Okay, thank you, doctor. So Dr. SC of Ethiopian Kidney Care wants to know whether the manual BP measurement and the digital ones have a measurement difference. At that time, you can also answer Dr. Gauri Shankar's question as to whether you should be sitting when you take BP or is supine position allowed.
Muruganathan.
Mumtaz? Okay.
Mumtaz wants to answer that. Mumtaz, please.
Yeah, no, either way, I can answer and then please do supplement as well if I don't mention. So picking up the second question about supine or sitting, ideally we want it 45 degrees kind of sitting sort of blood pressure measurement, because they can vary when lying down, but also when sitting up and standing as well. So that would be ideal. But of course, patients who are in hospital who you are unable to measure sitting up because their blood pressure might drop and things, then that might be a different sort of reason for doing it differently. And then the other question was around, sorry, what was the other question?
About whether the manual BP and digital BP machine.
Okay. So now in the hospitals, we just use the digital blood pressure monitoring. We don't use the mercury ones at all. So I think previously there was a misnomer thinking that one was better than the other. But again, I think your previous point, Dr. Dr. Muruganathan, was the quality as well, because different blood pressure monitors might be of different quality. So as long as the quality of the blood pressure monitor is good, then there shouldn't be a difference. Is that fair for your context as well, Dr. Muruganathan?
Yeah, I will add one more point. Whenever you measure the pressure, especially in the elderly person, apart from sitting and lying, you should do postural hypotension to rule out. Make them stand for 3 minutes, and you must take the blood pressure 1 minute. Then after 3 minutes, and if the fall in blood pressure is more than 20 systolic, you must alter the drugs, or you should reduce the drug, especially in the elderly person, because there is a fall chances. So especially frail individuals, you must be very careful. Again, in a diabetic patient, postprandial hypertension also is there. So you have to check the elderly person postprandial also. So depending on, see, in those days we used to check the pressure. Georgie will agree with me, always in the supine position. When the patient comes, in the board rounds, we check only the supine position. And then nowadays only the accurate blood pressure measurement is sitting, back rest and things like that. But in a pregnant woman, I said lateral decubitus can be done. So that is one thing.
Left lateral.
Yeah, left lateral decubitus. And then coming to the different machines, the manual BP monitors, now the mercury is going out of order. Now, we don't have manual. But anyway, when you give a home BP monitor or an automated BP monitor, you always standardize with the mercury monitor. You ask them to bring the machine, check whether it is all right, because sometimes the manual errors are more. Nowadays, a very beautiful automated BP measurements are there. In fact, the SPIN trial, 9,000 people they have made diagnosed only with the automated BP monitor. Very good. But only caveat is that the automated BP measurement is 5 millimeters or 10 millimeters less than the manual BP monitor. So that is also, you will have to keep it in mind. And then accordingly, you should do. Suppose somebody has got 120/18 automated manual, automated machine, it is more than 130 or 140 in the manual. So you should always compare and then have that in mind, so that, when you treat or titrate, you use those points. Sorry.
I just want to add to Dr. Muruganathan. Now, complete automated blood pressure monitors are available, which checks the blood pressure 3 times. So it gives an average of 3 times, and these devices are available in India. And I usually promote that in my hypertension patient who would like to take the blood pressure at home.
Yes.
Thank you, Dr. Purnima Kashyap wants to know, how do you bring your BP back to normal, and what practice and food habits would help?
Mumtaz, you could, being a lady, you could answer that, and Muruganathan can make a comment.
Yeah, okay.
Oh, bless you, no problem. That's fine. So I think, diet-wise, I think the important factor is low salt diet, because I think a lot of our diets have maybe too much salt, particularly in the Asian diet. So they say reduce the salt to less than 5 grams a day, eating healthily, kind of just more of a balanced diet. I think in India, you don't have enough, you have more than enough access to fruit and vegetables on a regular basis, and then avoiding the saturated fats as well. And other lifestyle measures, we've talked about smoking and alcohol and just being more active. So many of our patients with borderline hypertension in the UK, but I'm sure this is relevant everywhere, is that the first line of management is the lifestyle changes. And then, if the blood pressure still remains high, then we go on to medical management. But then the ongoing dietary measures are important, even if you are on tablets. It doesn't mean if you're just on blood pressure tablets, you don't need to worry about all your salt and dietary intake as well. So those would be kind of my take. So ongoing, kind of preventative lifestyle changes will help you sort of improve both reducing the risk of getting hypertension, but also reduce the risk of prevention.
Dr. Muruganathan.
I will add. Okay, so in the lifestyle modification, again, thanks to Georgie, he's a motivator for me. So don't mind, I use some jokes. I always call it is not lifestyle modification, it is wife style modification. In India, many times the wife only, does she's the head of everything, not only cooking, in the house also, finance, everything she only heads. So she knows what to cook. If a wife knows, she can reduce the salt. She can add DASH diet. We talk every time DASH diet, but touch our heart and tell me, how many of us take 3 times vegetables, 3 times fruits? We only say DASH diet prevents the hypertension. We don't, follow DASH diet. But if the lifestyle modification, if the wife knows, if the wife is educated, she will reduce fat, she will reduce salt, she will give more vegetables and fruits. Suppose if the husband is not active, she will give the dog and say, take the dog for a walk. So whether you are doing a walking or not, she motivates the husband and the family to walk. Another thing, in a Western country, I forget the name of the place, Mumtaz, you must be knowing, people are encouraged to use the steps, not the lift. And if you are very religious, you go to mosque by walking, you go to temple by walking, you go to church by walking, not by car. In that particular town, the corporation has given there is a lift there, but there is a staircase also. The interesting thing in the staircase, if you go in the staircase, every step you do, there is a music, ding, 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 dang, ding, ding, dang, dang, like that in the community. So that is the one best way of motivating the people to use the stairs instead of the lift. So these are the lifestyle modification, which is very good for any problem, non-communicable disease, maybe diabetes, maybe cancer, maybe hypertension. So you ask to practice. When somebody comes to me, even if there is normal hypertension, I tell them, please practice lifestyle modification. Watching television for more than 2.5 hours every day itself is a risk factor. Watching television for more than 2.5 days is like smoking a cigarette. Please don't do that and do walking.
Right, thank you. One last question and then Dr. Georgie can wrap up also. Can we assess the nocturnal dipping, reverse dipping by checking manual BP or only by ABPM? Also highlight the timing to check BP for assessing nocturnal BP. Question from Dr. Gauri Shankar.
Muruganathan, please answer that question.
Okay.
Muruganathan.
See, now we have got to see, in those days, we talk about hypertension means management only in the clinic. Somebody has got 180, 110. When they come to the clinic, and if you see the blood pressure is reduced, we are happy. Now we are not happy because when it comes to the office BP may be normal, whereas the home BP may be high. I saw Kaushalya's question. Her BP always in the home is high. So I think she should check, she should rule out mask hypertension. When the blood pressure is normal in the clinic and the blood pressure is more in the home, it is, it's a mask hypertension. Many times, the home, there may be some problem for them. That's why the blood pressure is more. So I always say the home BP monitor is the key for diagnosing that. Okay, coming to the, what was your question again? You're sorry, Lata, you were saying.
About the, this was for assessing, can we assess the nocturnal dipping?
Okay, coming to nocturnal dipping. See, nowadays, we are not happy only checking the blood pressure at office. We have to do, even to diagnose, many international guidelines says, don't diagnose hypertension by only blood pressure at the office. You should reconfirm with home blood pressure monitor or ambulatory blood pressure monitoring. At least one hypertensive patient every year should undergo ambulatory blood pressure monitoring. Ambulatory blood pressure monitoring only can diagnose nocturnal dip. By manual BP monitor, we cannot diagnose nocturnal dip. If you are really want to diagnose, you have to check series of blood pressure during night, which is not possible. But one good news has come. I think Mumtaz also will agree with me. There is now one home blood pressure monitor available, which is now come to the market where you can program it. The ambulatory blood pressure has got some problem. It is not patient friendly. It disturbs your sleep. Whereas this home BP monitor, which is introduced recently, you can program it and very nicely you can sleep. It records at 1 a.m., 2 a.m., 3 a.m., 4 a.m. You can program it. So it's just like ambulatory blood pressure monitor, but it's a home blood pressure monitor, which will easily find out nocturnal blood pressure. So now the key in the diagnosis of hypertension, not only diagnose during the office, you should also rule out nocturnal hypertension. You should also rule out early morning surge. You should also rule out BP variability. You should also rule out the BP on all the 24 hours. BP all the 24 hours, it should be, this is called time in target. Time in target is very important. Now, latest thing. I'll give an example and then, I'll hand over to George. Suppose somebody takes a short-acting hypertension drug from morning to evening, the blood pressure is under control. So they come to my clinic. I check in the morning also, evening also, blood pressure is normal. Whereas this pressure will go up in the night. So we are introducing what is known as iatrogenic masked hypertension. When somebody has got hypertension, you make them as a masked hypertension, an iatrogenic masked hypertension. Because when you give a short-acting drug, for example, chlorothiazide, 6 hours, 8 hours it acts, the blood pressure is under control. You are happy. But the nocturnal hypertension becomes a big problem, which we may not know. So we are introducing this masked hypertension. This is called iatrogenic masked hypertension. That is why when you choose a drug, It should be 24 hours drug with the BP variability reduction, with smooth functioning. Trough peak ratio should be now normal, and it should cover 24 hours. Otherwise, when you give a drug, you are not only controlling off, you are also creating problem. So this is a new concept called time in target, and that's how the selection of drug is important. That is why combination of the drug is important, which will prevent all these problems.
I had two questions which I saw. One is from Purnima OMR. Purnima, are you overweight? Do you take a lot of salt in your diet? And have you checked your kidney functions since you have hypertension? So what you should do is, I always do is home blood pressure monitoring. You have a reasonably good digital automatic instrument. You get up in the morning, empty your bladder, sit on your bed or chair, have the sitting blood pressure checked and record it. And in the evening before you go to sleep, empty your bladder, check your blood pressure, and do it for about 5 days. So we have about 10 recordings. So if these 10 recordings are showing high blood pressure, you need to have your kidney function checked, doing a simple serum creatinine level in a reliable lab in the city. Don't go and do it in every lab. And also a routine urine examination, and then have your physician assess you. The other question was early morning dizziness. Is it due to hypertension or hypoglycemia in a diabetic? It could be due to both. Hypertension doesn't give rise to dizziness unless you have postural hypertension, that the blood pressure drops by more than 20 millimeters of mercury. It is possible that early morning dizziness could also be due to hypoglycemia. Please check your blood pressure to make sure that you are not going into low blood sugar of less than 70 milligram per deciliter in the morning. I think we should wrap up now. And it was a wonderful session with Mumtaz and Dr. Muruganathan, my close friend. And I thank both the speakers, and I could see questions coming from other parts of the world, including Africa and other countries. So thank you very much, Dr. Lata Kumaraswamy and Dr. Louis and Dr. Alan and Kausi for arranging this session. And Muruganathan has raising his arm. One quick brief comment, Muruganathan, please.
My drive home message to all of you is kindly promote hypertension clinic, hypertensionologist and hypertension center of excellence. Buy a validated BP monitor. Have 3 different cup sizes. Every clinic has got a BP monitor, all right, but not three different cup sizes. For thin people, obese people, you should have different cup sizes. Otherwise, accurate blood pressure measurement is not possible. So accurate blood pressure measurement is the key. So please promote this blood pressure, home blood pressure monitor, and also accurate measurement, and promote hypertension clinic and hypertensionologist. So Mumtaz, please promote this concept of hypertensionologist all over the world, because there is no hypertensionologist. We are very, very unhappy because I call myself as hypertension specialist. I don't have any name. They say hypertension specialist. You should have like a diabetologist, hypertensionologist. Thank you, Mumtaz.
Yes.
Thank you.
I just want to say on behalf of IFKF WKA and on behalf of our president SF, just our grateful thanks to Dr. Georgie Abraham for moderating this and actually suggesting and getting this webinar going. To Dr. Muruganathan, grateful thanks to you for organizing this with the Zoom and with everything and all your wonderful ideas. I think it's just brilliant. It can be replicated all over the world. Dr. Mumtaz, for all your wonderful, insights into BP and all the attendees who are here today, to Kausalya for having organized this. She's part of IFKF WKA. Any questions you have, please send it to info@ifkf.org. And we will pass it on to Dr. Mumtaz Patel and Dr. Muruganathan. So you can expect a lot of questions because a lot of people would like to know more about BP. I think today's session, we've learned so much. I want to say grateful thanks to all our attendees and to each and every one of you. Thank you.
Thank you for giving me an opportunity to share the dais with Mumtaz, such a calm and pious and nice lady.
And Purnima, your BP is, I know you're a cool person, but as Dr. Georgie said, you need to check, and we may all seem cool outside, but I'm sure there may be a lot of anxiety inside. So let's follow what Dr. Muruganathan and Dr. Mumtaz Patel say, and keep ourselves healthy. That's what IFKF WKA and the World Kidney Day is promoting. So it's just health, kidney health for everybody everywhere. Okay. Thank you so much, each and every one of you.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Thank you, doctor. We will end the meeting now.
The recording is available. So anybody wants, we can give the recording because we have already recorded the proceedings.
Thank you. Grateful thanks, doctor. To you and Mumtaz, wonderful. And SF,
thank
thank you
you.
for staying awake. Because
Bless,
it's
very
I
late.
know it's very late in Hong Kong, but thank you so much.
Oh.
And all the attendees.
Thank you. Thank you,
you.
Dr. Georgie. We are ready for the next one, next topic for the next webinar.
Yes.
Oh. Thank you.
Thank
Take
you.
care now. See you again.
Thank you.
Bye-bye.
Thank you,
See you.
Dr. Mumtaz.
Bye-bye.
Thank you, Dr. Murugadan.
Mumtaz, see you day after tomorrow. Allah, 1:40,
Yes.
30. Yeah,
Take care.
Monday.
Take
Next
care.
Monday.
Thank you, Georgie. Bye-bye now.
info@ifkf.org. Please post all your questions there. Thank you once again, everybody.